Stephanie Huff, and I am recording another concept of acid-base balance. This time it's on metabolic acidosis. Just to review metabolic acidosis, this is characterized by a low pH, less than 7.35, low bicarbonate, less than 24. It can be caused by excessive acid in the body or loss of bicarbonate from the body. Your respiratory system attempts to return the pH to normal by increasing the rate and depth of respirations. There are three basic mechanisms that can cause metabolic acidosis. The first one is the accumulation of metabolic acids. This can be caused by an excess production of acids, an impaired renal elimination of your metabolic acidosis, and high anion cap acidosis, which is buffering of excessive acids by bicarbonate. Another mechanism is excessive loss of bicarbonate. This could be through intestinal suction, severe diarrhea, ileostomy drainage, or fistulas. The third mechanism is increases in chloride levels. This could be hyperchloremic acidosis when excess chloride solution, sodium chloride, is infused. That could cause this. It could also be related to renal disease. Looking at the pathophysiology, acidosis depresses the cell membrane excitability, affecting neuromuscular function. It also increases free calcium in the extracellular fluids by interfering with protein binding. Severe acidosis depresses myocardial contractility and leads to decreased cardiac output. If kidney function is normal, acid excretion and ammonia production increases to eliminate excessive hydrogen ions. Acid base affects electrolytes in acidosis. So potassium is retained as the kidney excretes excessive hydrogen ions. Calcium is released from its bonds in plasma proteins. It increases amount of ionized, which is free calcium in the blood. Magnesium levels may fall. Risk factors: metabolic acidosis usually develops during courses of another disease. Acute lactic acidosis results from tissue hypoxia from shock or cardiac arrest. Type 1 diabetes mellitus increases the risk for diabetic ketoacidosis. Acute or chronic renal failure impairs the excretion of metabolic acids. Diarrhea, intestinal suctioning, and abdominal fistulas increases the risks for excessive bicarbonate loss. Manifestations: general manifestations include weakness, fatigue, headache, and general malaise. GI manifestations could be decreased appetite, nausea, vomiting, abdominal pain. Neurologic manifestations: level of consciousness may decrease into stupor and coma. Cardiac manifestations include dysrhythmias and cardiac arrest. Integument manifestations: warm and flushed skin. Skeletal manifestations: chronic acidosis, decreased calcium and phosphorus released from the bones. Compensatory mechanism is Kussmaul's respirations, which are deep, rapid respirations. Collaboration focuses on treating the primary disorder. Diagnostic tests include ABGs, serum electrolytes, and tests as indicated by the underlying disorder. Pharmacologic therapy: alkalizing solution for pH less than 7.2. So this could be through sodium bicarbonate is probably the most commonly used solution. Others used are lactate, citrate, acetate solutions. These are all metabolized into bicarbonate. They are given IV for severe acute acidosis or orally for chronic acidosis. Careful monitoring is required when treating with bicarbonate Rapid correction of acidosis can lead to metabolic alkalosis and hypokalemia. Hypernatremia and hyperosmolality may develop, causing water retention and fluid overload. Diabetic ketoacidosis is treated with IV insulin and fluid replacement. Alcoholic ketoacidosis is treated with saline solutions and glucose. Your lactic acidosis is from decreased tissue perfusion. You need to correct the underlying problem and improve tissue perfusion. Chronic renal failure can cause mild to moderate metabolic acidosis. Some of this may not need any treatment, but treatment will depend upon the pH levels as well as the bicarbonate levels. Diarrhea causes metabolic acidosis, so you want to correct the underlying cause, provide fluid and electrolyte replacement. Nurses need to be aware of acidosis and its effects and the implementations for nursing care. Discuss management of underlying disease process, which could be type 1 diabetes and renal failure. Early manifestations a lot of times resemble viral disorders like influenza. You want to stress the importance of seeking treatment promptly for your patients. Assessment. Current manifestations could be decreased appetite, nausea, vomiting, abdominal discomfort, fatigue, and lethargy. You want to find out the duration of their symptoms, any precipitating factors that could include diarrhea, ingestion of aspirin, methylol, or ethylene, chronic diseases such as diabetes, renal failure, cirrhosis, or endocrine disorders, and their current medications they're on. Physical assessment is going to include monitoring their mental status and level of consciousness, vital signs including respiratory rate and depth, as well as the apical and peripheral pulses. You want to assess the skin color and temperature, abdominal contour and distension, assess bowel sounds and urinary output. Diagnosis is focused on the primary disorder that's the cause. These are your possible NANDA nursing diagnosis for acidosis. In planning, potential goals are that the client will describe and demonstrate preventative measures related to chronic disease process, have a pH remain within normal range, have disease process causing the imbalance controlled to reduce acid production and alkaline loss, maintain vital signs within normal ranges, maintain baseline cardiac rhythm, maintain or regain normal serum electrolyte levels. Implementation. Nurses' interventions may include the following tasks: monitoring their cardiac status, which includes monitoring vital signs, peripheral pulses, capillary refill, monitoring their ECG pattern for dysrhythmias and hyperkalemic changes, monitoring lab values. You want to monitor for potential excess fluid volume. This is done by maintaining and monitoring fluid replacement as ordered, monitoring their serum sodium levels and osmolality, monitoring heart and lung sounds, monitoring their central venous pressure, monitoring respiratory status, assessing for edema. In the back and sacral area is going to be important for your bedridden population. Periorbital edema will indicate a more generalized edema. Monitoring for potential for excess fluid volume. You want to assess the urine output hourly, maintain accurate intake and output records, obtain daily weights using consistent conditions like we've talked about many times, administering their prescribed diuretics, reducing the risk for injury. You want to monitor their neurologic functioning, including their mental status, level of consciousness, and muscle strength. You want to institute safety precautions like the bed in lowest position with their side rails elevated. Orient them to time, place, and circumstances as needed. Just keep them reoriented, especially if they have confusion. You want to keep familiar objects nearby and allow significant others to stay with the client. That helps them feel more secure and helps decrease their anxiety. Care in the community is going to focus on the underlying cause of the imbalance. Interventions in teaching to prevent further episodes of acidosis, which could be from diabetes, starvation, alcoholism, renal failure, diarrhea, ileostomy drainage. Evaluation. Expected outcomes can include client maintains their pH within normal range. Their client's vital signs remain within normal range based on age and condition. They will maintain adequate oxygenation of their tissues, and they are able to describe or demonstrate measures to prevent further complications of pH imbalance. So this is the end of metabolic acidosis. If you have questions, please let me know and I will try to help clarify.